So let's do a couple of pre-test questions and then have Dr. McLeod come back and walk us through this challenging topic. Here's a 21-year-old female with a history of unexplained syncope undergoing a tilt table study. Following a 2-minute prodrome, the heart rate reduces to 29, the blood pressure to 40, and she faints. A class 1 recommendation for therapy in this situation includes beta blockers, education on diagnosis and prognosis, education on physical counterpressure maneuvers, initiation of mitidrine for this vasodepressor event, or initiation of fluticortisone. Ooh, okay. You have some work to do. Question number 2, secondary prevention ICD implantation is indicated in which of the following situations following effective AED use in the community? A 51-year-old diabetic female with dialysis-dependent kidney disease, recurrent hypokalemia, and 3 prior torsade-related resuscitated arrests. A 55-year-old male with bipolar mood disorder using lithium, Seroquel, and treated with levofloxacin for sinusitis, resuscitated from sudden cardiac arrest at his group home. His presenting ECG shows a QTc of 610 milliseconds. A 19-year-old male resuscitated courtside during a college basketball game and found to have pre-excitation on his baseline ECG. Or D, a 66-year-old woman with known coronary disease, an EF of 47, but no culprit lesion identified on emergency coronary angiography. Which one of those people needs a secondary prevention implanted defibrillator? All right, Dr. McLeod. Thank you very much for being here again.
Thanks, Steve. Hi, everyone. So I find that syncope is just really poorly understood across the board. And it's always baffled me why it's sort of all cardiologists that should deal with it. To me, it shouldn't be cardiologists dealing with it. But whether you like it or not, especially for the fellows, when you go out into practice, this is such a common diagnosis that you're going to have to deal with. It really should be in the realm of the autonomic neurologist or the neurologist or even a specialist who really cares about the patients and syncope in that regard. It's really the bane of a lot of our existence in EP world. We want to see someone who we think we can really help with an ablation catheter, and here they are falling all over the place with no EP problem at all. But I do think we can really help them. And so I want you to leave today really understanding the topic. And so please stop me afterwards if none of this is clear. It's always on the boards. And as I said, you're going to see it all the time in real life. So transient loss of consciousness, that's what this is. But there are other causes, as you know, non-traumatic causes. And you're going to have to differentiate through those non-traumatic causes based on the history alone. There's the traumatic ones, and then there are these mimics, which really can be hard. But really, just on the history alone, getting some feedback from the family in particular or someone who witnessed the event is usually key. So just to frame the discussion then, transient loss of consciousness, often leading to falling, relatively rapid onset, and usually spontaneous recovery that is complete and prompt. And the underlying mechanism here is transient global cerebral hypoperfusion. Not enough blood getting to the brain. Okay? So 19-year-old healthy female often feels queasy with exposure to blood, loses consciousness during a hospital tour, diagnosed with vasovagal syncope, or syncope due to cerebral hypoperfusion. How long do you think it is for this patient to lose consciousness? 2 to 4 seconds of not enough blood getting to the brain, 5 to 7 seconds, 8 to 10 seconds, over 12 seconds. It's important also when you see those Holters or overnight oximetry, and you can see even during sleep apnea the heart pauses for a period of time. How long do you think it would take for the patient to black out? Yeah, so majority of you got it right, and we're just going to step back a little bit and do a history lesson. The reason I include this is more for the just unbelievable ethical contravention at the time. And so these were patients who were prisoners at the Red Wing Reformatory down the road here in Minnesota, who volunteered, and some of these patients even went back more than once for more than one test. And so what was happening in World War II at the time is that the bombing airplanes were reaching such G-forces that the pilots were blacking out. So they developed this National Dysautonomia Research Foundation. They put a whole lot of money into this, and they tested prisoners around the United States, but especially here in Minnesota. This was the place in Red Wing. And how they did this is they created this sort of cuff, which is like the sphygmomanometer, the blood pressure cuff, and it was gas infused, and the patient held a switch, and when they blacked out, obviously the hand collapsed off the switch, and they blacked out. And so we were just this is where you get your information. How much hypoperfusion is necessary for someone to black out? So it is amazing to me that there were several inmates who even came back for this more than once. It's something that's never, ever going to be repeated. And here you can see the data really nicely recorded, 5 to 7 seconds. And how they knew they had blacked out was they looked at sort of the fixation of their eyes during acute arrest of cerebral circulation in 111 normal young men. So it is 5 to 7 seconds. That's sort of a thing that I would just keep in the back of your mind. If there's not enough blood going to the brain for that amount of time, the patient is likely going to pass out. So syncope, as I alluded to, huge problem in the United States. Lots of emergency room visits and hospital admissions. And so I'm going to break it down into these 4 main categories. So neurocardiogenic, which is reflex-driven. And so we'll go through the reflexes there that can trigger this. Orthostatic, this is affecting the vasculature themselves or the nerves themselves, but is triggered by orthostatic movements, by standing up from the lying or seated position. Arrhythmogenic, bradycardic, pauses, tachycardic events. And then cardiovascular would be valvular heart disease, the atrial myxoma, hypertrophic cardiomyopathy, and we'll go through those. So neurocardiogenic syncope, and this is the one that I think is least well understood. Here we really are looking at a trigger. What is the particular trigger that initiated what in this group of patients is a maladaptive or an abnormal reflex? Normal reflexes should not do this. So the vasovagal fainting episode, which is sort of the poster child for neurocardiogenic syncope, is just one of those reflexes. And so there are others here, but the trigger here is a reflex where in the vasovagal patient who you saw that background on earlier, it was the sight of blood, or it was pain from phlebotomy. It was something like that that triggered this reflex, and the reflex in this group of patients is abnormal. But there are other reflexes here which all make up this syndrome of neurocardiogenic syncope, and they're all different triggers. So it really is a failure of reflex vasoconstriction. And here's a nice example of that. We think of failure of reflex venoconstriction in the periphery, in the legs obviously, and that's why we often suggest stockings for these patients, compression garments. But this study and a lot of new data to emerge shows that this is widespread throughout their body. This is in their arms. This is also, here you can see splenic vasoconstriction. And they looked at the splanchnic tone throughout the GI circulation. And so there's about a third of the blood getting pooled in the belly for some of these patients, not just in the legs and not just in the arms. Sort of opens up the opportunity here for treatment. So here we can see calf blood volume. These are patients whose who do have vasovagal syncope, and these are normal controls. There's much more blood volume in the calves for patients who faint in a vasovagal manner, but also in the splanchnic bed. So there's pooling of blood throughout the body initiated by an abnormal reflex triggered by some particular stimulus. So if you were to tilt someone to recreate that event, you tilt them long enough to allow for some central venous pooling, and because the central venous pressure is going down and ventricular filling goes down, these baroreceptors are activated, and through the glossopharyngeal nerve, vagal nerve, the brainstem then needs to coordinate what is a normal response, increasing the heart rate, but also vasoconstriction. And this is an abnormal reflex in these patients. But we know now that this can be retrained. If it can't be retrained, then you're going to need to somehow support the vasodilatation. So that would be with garments that are lower extremity compression, or even abdominal compression garments, which I'll show you some pictures of. So these maladaptive abnormal reflexes, and they would stretch across all of these syncopal syndromes. So the vasovagal syncope, where it's panic or fright or pain; carotid sinus, where the carotid sinus body is activating and initiating the impulse; situational syncope, I'm sure some of you have seen this with coughing and sneezing; or micturition syncope is a very common one. And then even people with glossopharyngeal and trigeminal neuralgia, throat pain, or drinking hot fluids can trigger this in some people. So it's understanding the trigger for that event, and we'll get into the management in a minute. Just making sure you understand that this is different from orthostatic hypotension. So the orthostatic issues here are really driven, or the initiation is not reflex driven. This is initiation to standing upright. They stand upright, and their blood pressure is not maintained, either because of primary or secondary autonomic failure. And you saw the reflex pathways there. And so drugs is just such an important one here to recognize. These are usually elderly patients, and I go about stopping their Norvasc or their hydralazine or something that's going to lead to venous pooling, which they can't compensate over because of their relative autonomic failure. And obviously volume depletion is part of that constellation of reflexes. The arrhythmias, this is an obvious one, and this is why they end up with cardiology. Any kind of sinus node dysfunction, AV nodal disease, paroxysmal SVT and VT. Very often here, the paroxysmal SVT or the AFib, it's suppressing the sinus node when it breaks, and the sinus node is slow to recover. It's very rare that SVT would cause this. And then obviously the inherited channelopathies. Cardiovascular causes, I would read through these. I'll show you a couple of examples, but valvular disease, especially aortic stenosis. I saw a patient just last week with a gradient of 65 millimeters of mercury, and he was coughing and would black out. So 3 syncopal episodes for tight AS. Hypertrophic obstructive cardiomyopathy, the myxomas, dissection, the obvious ones. So for lots of things in EP, I think it's, at least for the electrophysiological phenomenon, so easy to just look at an ECG or look at a Holter or an EP study and you know exactly what's going on. I don't even need to speak to the patient. But this is all about the history. That's how I think about syncope. There's so much important stuff in the history here that is going to send you down one diagnostic path or another. And I would just start off by the background here. So recognizing that a young person coming to see you, below the age of 40, more than likely the driving cause for their syncopal episode is neurogenic. So that would be your typical vasovagal syncopal patient who has a history of this all through childhood usually, or adolescence, and this is a recurrent event triggered by some stimulus. As the patients start to get older, you can see there's more likelihood of those causes changing to sort of structural disease issues and even orthostatic hypotension. So some kind of primary or secondary autonomic failure. And then structural heart disease, more common in the over 60s. If you're looking at the history more carefully, it's going to be more likely to be cardiac syncope in someone with structural heart disease. Exertional syncope should always worry you. And I would here definitely make the distinction that this is exertional syncope, not post-exertional syncope. Someone running on a football field who collapsed sort of midway down the pitch, not good. Someone who has run the marathon, gets to the end, puts his head between his legs, and then stands up and passes out, that's almost always neurocardiogenic or vasovagal in some way. But someone running during exercise, it's an arrhythmia till proven otherwise. So that's our hypertrophic cardiomyopathy, CPVT, something like that. So during exercise, cardiac syncope. The age, as we spoke about, supine syncope very rarely would be neurocardiogenic. History of this, 2 or more spells. And then these prodromes are going to start shifting you more towards vasovagal, because the arrhythmogenic faint is going to be abrupt. You're going to go from a blood pressure with a systolic of 130 to 0. And here, as the blood pools in the periphery, you're going to get these prodromes, and it's usually 1 to 2 minutes. These patients do have some warning, and that's why we can teach them or train them to avoid pooling by counterpressure maneuvers. So the predisposing situations, the needle stick, the seeing blood in the hospital, something like that, the prodromal symptoms we discussed, physical signs, just making sure that there is no tonic-clonic motion. That one can fool people, though, because the brain will, if it doesn't have enough oxygen or blood for long enough, you can get seizures. And so very often the long QT patient presenting on 3 or 4 different anti-epileptic medications, but goes into SARDs before hypoperfusion of the brain, and it's the hypoperfusion of the brain that caused them to seize. So just making sure you've got the sequence of events there better understood and clarified. And then in the recovery time, the vasovagal things, patients are generally not good for the rest of that day. It's interesting, it does really affect them. So the diagnostic approach, we capitalize certainly on the history, making sure that your physical exam, you're excluding the aortic stenosis, that the ECG doesn't show any deeply inverted T waves consistent with non-compaction or hypertrophic cardiomyopathy. And by this stage, you probably would have identified the bulk of these, so orthostatic or neurocardiogenic at the core, at the source of that symptom. So if you're no further along in your diagnostic approach, then you have to go down this route of unexplained syncope, and you really should break it then into whether this patient has an abnormal heart or a normal heart. So patients with an abnormal heart and unexplained syncope, we've done an ECG, make sure that you're clear on the degree of aortic stenosis or hypertrophy, if there's an HCM background. The Holt is always very important to look for any episodes that may have been missed, and it may even be here that this is left main occlusion and syncope with that. So just making sure that all your bases are covered, and I know this is quite straightforward for most of you, but once you get to this stage here, what do you do if you still don't know what's going on? Really, do you send them for an EP study, or do you put in a loop recorder? This really should be based on your concern about that patient. Is it really safe for them to leave the hospital? If that was to happen again, that syncopal episode, would it be catastrophic? Or did they have enough warning that they could pull the car over? Things like that. And you'll never be wrong to send this patient for an EP study. We may not get the answer, but I do think that's in some instances that's the safest way. But if you think this is very rare, it was quite some warning, then fine to put in a loop recorder or even a 30-day monitor and see. So we have discussed this briefly here, hypertrophic cardiomyopathy, making sure that you're clear on the degree of outflow tract obstruction, alluded to it often by the ECG. Non-compaction is something not to miss. In my practice, a lot of these patients I would do an EP study on, just to make sure that there is no inducible ventricular arrhythmias. There's sometimes delayed enhancement on the MRI and scar within the non-compacted segment that can lead to reentrant ventricular tachycardia. And the myxoma, often a board's question, but I haven't seen one of these in real life. Aortic stenosis, this would be perfect for the board's question, and these kinds of things would elude you in the stem of that question that this is severe aortic stenosis. So unexplained syncope in the normal heart, if it's a single event or a rare event and you think this is not really malignant sounding, you don't have to investigate this any further. Recurrent events or frequent events, reasonable to go and look at this neurocardiogenic axis. So making sure that there isn't any obvious orthostatic hypotension, and there is a strict definition, a drop of more than 20 milligrams of mercury, of the systolic blood pressure, or more than 10 of diastolic, within those first 3 minutes of standing, which is different from a tilt study. A tilt study, you're going to see a change in their reflexes much later on. Carotid massage, you would call that positive if you saw asystole for more than 3 seconds, or a drop in systolic blood pressure more than 50. And then the tilt study really is looking at this axis, this neurocardiogenic axis. And these are some of the findings that you can see. So this is a vasodepressor response. And so we've got 2 ECGs on the top lines here, and then we've got the blood pressure here on this bottom line. So blood pressure, blood pressure, blood pressure. And you can see at baseline, supine, systolics in the 150s, they drop down to the 70s, and then they come back up after you put the patient supine again. And you can see here the blood pressure has gone down, but the heart rate was unchanged. In fact, the heart rate even picked up a little bit. So reflex to increase heart rate, but unfortunately a pure vasodepressor response. The cardioinhibitory response, here you can see on the bottom again the blood pressure and the lack of blood pressure driven by this cardio inhibition, no heartbeats. 9-second pause, and then slowly recovers again. This is very often preceded by slowing in the sinus rate, and then you'll start dropping beats, or you can see the sinus node hold altogether. The mixed response is often more commonly seen, and this is a bit of both. Here you can see the heart rate at baseline in the fast range, blood pressure, systolics in the 160s. You can see the blood pressure comes down, 50 systolic, but there wasn't really any pause. And a heart rate of 39 beats per minute isn't going to make someone black out. It's not going to help when the blood vessels are dilated like that. And it should have really been a little bit faster to compensate, but this really is a mixed response. And so here, this patient did have a pacemaker, a temporary pacemaker. You can see pacing this patient rapidly, and it doesn't really recover. So heart rate's still on the low side. So mixed, but then you would see that this patient probably wouldn't respond to permanent pacemaker implantation. So it would be this pure cardioinhibitory response that you would be looking for if you thought this patient really is going to benefit from a pacemaker. So these are the recommendations. There have been a couple of statements coming out from over the last 12 months. There's this one on POTS and inappropriate sinus tachycardia, vasovagal syndromes, and looking at investigation and treatment. So we'll start off with tilt table testing. So if you suspect vasovagal syncope, but you really are not sure about it, very often, as I said, by that history, you should be sure. There's enough there in history. Usually you're 2/3 of the way there, or you're 100% there. This is for lack of certainty. And then if you are unsure really on what the episode looked like, so you're differentiating between the types of transient loss of consciousness. Implantable loop recorders for investigating vasovagal syncope. Are these people really having long pauses that they may be helped with a pacemaker, and you don't see that on a tilt, or you don't see that in hospital when they're on telemetry? Just need to make sure that you're not going to be recording an event that's going to be arrhythmogenic in a bad way. So you want to make sure that those patients are safe to leave the hospital. This is the only Class 3 recommendation for in this whole group of investigations, that you shouldn't be doing tilt tests sequentially to follow up, well, is the midodrine working? Are the garments working? So managing these patients, we're going to start off with just a couple questions, because this comes up all the time. So POTS, postural orthostatic tachycardia syndrome, is a common cause of syncope in the young women 17 to 25. Is that true or false? Yeah, and I think this reflects our understanding of it. So POTS is simply what it says, postural orthostatic tachycardia syndrome. It's not syncope. So if there's syncope occurring in someone who has tachycardia when they stand up, they probably just have more widespread autonomic dysfunction. And we'll go over the POTS, inappropriate sinus tachycardia milieu, which it really is. It's really not a clearly defined syndrome, but someone who has syncope, it's not clear, it's not really POTS. POTS is tachycardia. Atrial fibrillation commonly results in syncope in the elderly. True or false? Yeah, so I did allude to this earlier. So it's really, if you see someone with atrial fibrillation and there is a history of syncope, which to you sounds arrhythmogenic and it's not neurocardiogenic, just by description, there's probably underlying sinus node dysfunction. And the same sort of mechanism, why do people have sinus node dysfunction? It occurs in the elderly because there's progressive fibrosis in and around the sinus node, and it's that same fibrosis that leads to atrial fibrillation in a lot of these patients. So it's almost the same process, the same sort of fibrosis around the AV node that leads to impaired AV nodal conduction in the elderly. So managing syncope then, we'll get to the POTS and inappropriate sinus tachycardia in a moment, but just the low-hanging fruit, if you have an abnormal heart, you treat the cause. So aortic stenosis, hypertrophic cardiomyopathy, that kind of stuff. Ejection fraction less than 35% if they're on optimal medical therapy, then you're going to start thinking about ventricular arrhythmias, and the patients more than likely should be recommended an ICD. So in getting into treating the neurocardiogenic and the vasovagal syncopal episodes, I think it's good to understand this in the context of what we see a lot of, those are the acute episodes, but it's very often sort of merges with these chronic syndromes. So these chronic syndromes, this inappropriate sinus tach, this POTS that we had the question about, and chronic fatigue syndrome and also irritable bowel disease, or irritable bowel syndrome, they're very often occurring all in the same patient. And really, this is a manifestation of a more widespread autonomic failure. These patients, if you look at their responses, when you tilt them or you do an autonomic screen on them, very, very similar to the people who are very deconditioned. And that's often what happens. They become more and more deconditioned over time because they feel that their tachycardia, which is inappropriate, is malignant or bad. They can't do anything. And I'm sure you've seen them, but completely incapacitated by these symptoms. So just making sure you're not going to miss any obvious signs of sinus tachycardia, but once those have been excluded, inappropriate sinus tachycardia, there are some definitions. So the heart rate above 100 beats per minute at rest, or a mean above 95, and that includes sleep. They have these frequent multi-system complaints, also shared with the POTS group of patients. POTS don't have this orthostatic hypotension. It doesn't mean that they don't have something else too, but a clean POTS diagnosis is based specifically on this increase in heart rate with standing, within 10 minutes of standing. It's exaggerated and it is inappropriate for that physiological need. So looking at inappropriate sinus tachycardia, these patients, it's very often throughout the day, but then does sort of settle down when they're sleeping in the evening. It's not paroxysmal, meaning there's not an abrupt onset and offset to that tachycardia. That's more likely then to be AVNRT or atrial tachycardia. And the P wave obviously looks like sinus, but you can get some atrial tachs from that area, so that can fool some people. Just make sure there isn't a secondary cause. There really is a very consistent profile for these patients, more typically young women, especially healthcare workers, and there is a discordance between these symptoms and tachycardia. So there is enough data now, and this was part of that consensus statement recommendation, that regular, structured, progressive exercise program where they focus on interval training is enough to sort of settle down that inappropriate sinus tachycardia, and very often some of these POTS symptoms where they stand up quick and their heart rate goes up fast really can retrain that sinus node. As I said, these autonomic response very closely mimic a patient who's severely deconditioned, and we gradually get them back into an exercise program here by exercising them at very short intervals frequently and building up to 45 minutes, 60 minutes, 5 times a week. And I reassure all these patients that recovery is the rule, because they come into your office thinking that this is the end. They're incapacitated and they're not going to do anything ever again. But recovery really is the rule, and once they hear that, that reassurance really goes a long way. But that's borne out by a lot of those studies. We saw a patient the other day who had a port that was implanted by their cardiologist to give these boluses of saline, and the port was infected. So this is not good. I'm sure most of you realize that, but do not give these patients boluses of saline. You can retrain the sort of, or recondition the heart rate response in a more healthy manner. So overall management of syncope, orthostatic and vasovagal. So for vasovagal syncope, these are from the new guidelines which came out earlier this year. The only class 1, because there's just such poor data supporting this, but for sure we know that this is important. Class 1 is education and diagnosis and prognosis, a little bit like the POTS and the inappropriate sinus tach patients. They really need to understand the disease process and that it's not malignant and that it can be treated or remedied. The counter-pressure maneuvers really work, and I'll show you how the blood pressure can come up with that. And just making sure that salt and fluid intake is suffice. We don't normally prescribe salt tablets or anything like that. Midodrine is the only medication that is class 2A. The rest is class 2B, and I would treat it in that way, in a stepwise fashion for these patients. And you're not going to get any class 2B recommendation questions on the boards. There's just too much debate about it. But this really does react with enough peripheral vasoconstriction to help with these patients who have vasovagal syncope. So if they know that they're going to be standing that day for a long period of time, it's something that they can take preemptively, something that they can take when they're getting into an interval exercise program. So orthostatic hypotension, making sure that you've withdrawn the offending agents, the calcium blockers, the ACE inhibitors. I like to use beta blockers for these patients. There's just much less peripheral venous pooling. And acute water ingestion, there is some data that this can trigger a cold glass of water in the morning for these patients when they get up, triggers the glossopharyngeal nerve, and we've seen some increases in blood pressure related to that in some small cohorts. And dehydration, obviously, you're going to treat with water ingestion. So the compression garments, I'm going to speak a little bit more about, and the counter-pressure maneuvers, because I do think that they can work in select patients. So here's data for just showing how these reflexes can be retrained. So this is vasovagal syncope. I took 13 patients with frequent syncope, and they had syncope during a tilt study. They did daily tilts on these patients, 90 sessions, and then by the end of that, 12 of those 13 were able to tolerate a full-length tilt, which is 30 minutes, and none of them had syncope in follow-up. So this really is a reflex that can be retrained. We don't do tilt training, but interval training really can do very much the same thing. So upright exercise, elliptical, treadmill, whatever they're going to be able to do. Upright, run for a little bit, sit down, and then do that again. That's very much what the tilt is doing, what the tilt training is doing. You can see here these counter-pressure maneuvers, and most of these patients know what their prodrome is like. They know when they're going to have a syncopal episode. You can see here the blood pressure increasing just with squeezing the legs, crossing the legs, and it comes up significantly. This is a real effect. It really is, and this makes the case to use those peripheral stockings, but they're just so difficult to wear. It's why I showed you guys that data from the splanchnic circulation. So here's another example of that, the blood pressure coming up just with leg crossing and muscle tensing. It's a real thing that patients can abort the episode preemptively or just keep doing that if they're standing for a long period of time. But these compression garments, these are not so nice to wear. But these elastic binders, we can see just the median systolic blood pressure without doing any compression stockings can be affected by compressing the splanchnic bed. And so we've got into the habit of prescribing sort of those running shorts which go down to the knee but also extend up into the abdominal area, and that would compress some of the belly and some of the upper legs. And a lot of these patients are storing a lot of blood in the splanchnic region. So which patients then should undergo pacing? For vasovagal syncope, you really want to try and avoid it, because if you have vasovagal syncope, there is a situational trigger which can be identified, and then there are the other maneuvers. So it's only a Class 2B recommendation for patients who are greater than 40 with spontaneous pauses. Carotid sinus syndrome, the new guidelines from this year don't identify a particular time. It used to be more than 3 seconds bought them a pacemaker. But if you think that their syndrome of lightheaded spells, of recurrent syncope, is consistent with what you saw when you rubbed on their carotids, and that's the cause, it's a 2A indication for pacing. And then if they need a pacemaker for something else, and you think that they have carotid sinus syndrome as well, it would be reasonable to just put a pacemaker in. That's a 2B. So driving in syncope is such a common dilemma in practice, and the new guidelines insist that you know the local driving laws, because it is different from state to state. But for the first time, they've really come out with some sort of broad guidelines here, and I think they're very helpful. I don't know if the state laws are going to change based on these, but this is in the document, and I've included a reference for this document at the end. This is the one that came out just a few months ago. So we're going to go quite quickly through sudden cardiac arrest. These are patients that the sudden cardiac arrest really is an enormous burden on the healthcare system. It's how patients predominantly with ischemic heart disease would present, either known or their first manifestation. And then the things like the channelopathies are really just a small portion of patients who have sudden death. So it really is the bulk of these patients, they have coronary disease. And so this is the sort of approach or algorithm that I would like you to take home. So you can identify a lot just on history exam and ECG, but if not, I think reasonable, so someone survived a sudden death event, was resuscitated, to go ahead and get an echo or an angio and MR to look for pathology within the heart or within the coronary vasculature. This would take care of a lot of these patients straight off the bat. And then if you've done all of that, I do think it's reasonable for the EPs to get involved, because now we're looking at that sort of top 5% where we're thinking about channelopathies. And an EP study or a pharmacological challenge really should be next down the line. So with the pharmacological challenges, we're looking for Brugada using a procainamide infusion. And then long QT and CPVT we can bring out with an epinephrine challenge. So usually we do that in our lab, and then also ventricular stimulation if the patient, like in that earlier stem, ejection fraction of 45% but a prior infarct. Is there an arrhythmogenic area there? This is looking at patients who had gone through a complete workup. This was in Canada. So no evidence of gross cardiac disease, unexplained out-of-hospital cardiac arrest, resuscitated. And looking at epinephrine testing alone, they then identified long QT syndrome and CPVT in quite a number of these patients. What was really interesting was that the patients with bidirectional VT had CPVT, catecholaminergic polymorphic VT, but were negative for this ryanodine receptor, which is ryanodine receptor mutation, which is sort of pathognomonic for CPVT. So there really, it just is a spread of channelopathies out there which can be proarrhythmic, and you can identify who those patients are without knowing what the gene is, without knowing what the mutation is. You can identify, are they arrhythmogenic with an epinephrine challenge. So who should get a defibrillator after an episode of attempted sudden death? So this is secondary prevention. Acute MIs, in the context of ventricular fibrillation, so all should get them, except these four. So the boards want to make sure that you know that these are reversible causes. So if someone has an MI in the context, has VF or sudden death in the context of a large MI, the MI is the cause, they've been revascularized, it's no longer the cause, it's reversible. Iatrogenic QT prolongation with drugs, and then this one for sure, WPW. If you ablate that pathway, patients no longer at risk for sudden death from ventricular fibrillation. And then obviously any drug overdose or severe electrolyte abnormality. So these are the reversible causes. Everyone else who's tried to die once outside of the hospital, that shouldn't happen again. They get a defibrillator. The thing to remember also that when you put in a defibrillator for those patients, you're not treating VT, you're treating sudden death. So definitely then have a strategy on board to treat the VT. Otherwise, they're just going to get shocks. So either ablation or antiarrhythmics. And then just making sure you guys remember that after revascularization, you can't put in a device, an ICD, within the first 3 months. And after an MI, not within 40 days. So Syncope will round off with these final points. So I think the diagnosis is made very often on history, and then think about structural heart disease as sort of a juncture for investigation. Out of hospital arrest, make sure that you're excluding reversible causes before you move ahead with an ICD implant, and then waiting those prescribed times. Thanks very much for your attention.
Excellent. Okay. As you said, syncope seems to be not well understood. We all try to avoid it, both personally and in our patients. But thanks for taking us through that. So let's go over these few questions. The first is the 21-year-old woman with a history of unexplained syncope, and she's getting a tilt study. She has a 2-minute prodrome. The heart rate reduces to 29, and the blood pressure drops to 40 when she sinks. A class 1 recommendation for therapy for this person include beta blockers, education on diagnosis and prognosis, education on physical counterpressure maneuvers, initiation of midodrine, or initiation of fludrocortisone.
Great, yeah. So really just education about diagnosis and prognosis. You really have to reassure these patients and give them as much insight as possible. That's the only class 1 recommendation. Everything else I would then do sequentially after that. But even with this alone, a lot of these patients think that there is something catastrophic wrong with them. And I think we've sort of ushered in this pandemic of sinus tachycardia with the sort of with the Fitbit and with the way that you can record your pulse. You have patients who are like, well, I must be lightheaded. My heart rate's 110. You know, and then they do start getting a little bit lightheaded, and then they do start pouring out adrenaline. You know, and so I tell those patients to stop wearing their Fitbit, go and lock it up. Yeah.
So other than the counter pressure maneuvers that you talked about, is there a role for exercise for someone with the reflex syndromes?
Yeah. So interval training really is the only one that's been shown to improve vascular reactivity. So I tell patients not to go for a long run or anything like that. At this stage, a lot of them say, well, I can only make it a couple of minutes on the treadmill. Then I would say, well, do 30 seconds and then sit down. Get your heart rate down, let it come down, get your breath back and do another 30 seconds. So those intervals and then build up slowly. I tell them this is sort of a 6 to 12 month tough endeavor for them to embark upon, but they're going to get there. But interval training is the only exercise that's been proven here.
And that is retraining the reflexes. It's not necessarily muscular training of the legs or things like that.
Mm-hmm. So upright exercise. Swimming doesn't do it.
Doesn't count. All right. Question number 2. Secondary prevention ICD is indicated in the following situations following effective AED use in the community. So the 51-year-old diabetic female with dialysis-dependent kidney disease, recurrent hypokalemia, and 3 prior torsade de pointes arrests. A 55-year-old male with bipolar disorder on lithium, Seroquel, and treated with Levo for sinusitis. He's resuscitated from cardiac arrest at his group home with an ECG showing a QTc of 610. A 19-year-old male resuscitated courtside during a college basketball game and found to have pre-excitation on his ECG. Or a 66-year-old woman with known CAD, an EF of 47, but no culprit lesions on CAS.
Great. So really just making sure that you guys are not going to miss reversible causes. And so all of those are reversible except for the patient with the known coronary disease, ejection fraction of 47%, coronary disease meaning that it's chronic. It's not in the context of a massive myocardial infarction where most hearts are likely to fibrillate because they're anoxic. So just looking for those reversible causes. If there's anything reversible, you shouldn't go ahead with the defibrillator. Putting in a defibrillator in the patient here in question, this 68-year-old lady, 66-year-old lady, would have to do something for the VT.
Right, so treat the underlying disease.
Yeah, would make sure, otherwise they're going to get shocks. Shocks are a bad deal.
Absolutely. So there was a couple of questions again on, I mean, you had a nice layout for the treatment, but on using beta blockers or some of the other drugs in the POTS type patient. And again, it seems to me you mostly emphasize this as education, reassurance, and some of those exercises. But is there a role for drug therapy in the sinus tachycardia or POTS patients, beta blockers, et cetera?
So they're class 2 recommendations, but and I guess it is patient specific. Some patients feel better taking a beta blocker when they have tachycardia, and you really can't argue with that. You're treating their symptoms. Is it treating the fundamental cause here, which is predominantly deconditioning in the POTS patient, or a deconditioning type syndrome? You know, with POTS or inappropriate sinus tachycardia, very often there was a precipitating event. There was some viral syndrome, or there was some event where they were very athletic and then everything stopped. And getting back and retraining those reflexes is really getting to the source of the problem here. These patients are going to recover. Do they need a beta blocker? They don't need a beta blocker. Are they going to feel better with the beta blocker? Some of them are, because they really don't like the fast heart rates and the palpitations. But it's not going to change it in the long term. Midodrine I find quite useful, and I sometimes use it as a surrogate for exercise, as you saw class 2 use of midodrine here. Because if you can support the blood pressure just enough to get them to do an interval training regimen or workout, then you're getting there. You're using it as sort of a surrogate for exercise because they're so debilitated and so deconditioned. So using midodrine in increments to get them onto the treadmill, to get them onto the elliptical. When they're at their target exercise, you can bring back and reduce the midodrine dose.
Yeah, the other thing that here at Mayo that we've seen effective is combining therapy with our colleagues from behavioral health for some of these people. It's kind of like management of chronic fatigue syndrome in some ways, and you had that on the one slide. Because people are not only are retraining the reflexes, but retraining their symptom filter and understanding if you've had this repetitively, that's not the one you need to worry about. It's a change in symptoms, and you're teaching people how to deal with their condition rather than be afraid of it.
No, that's crucial. Even though a lot of us don't like seeing these patients that much, you can really, really help them. You can really change their life around. Yeah, that whole sort of cohesive program is much more complete, but this is really very much widespread autonomic dysfunction, autonomic or dysautonomia. That's really what it is.